Hi, my name is Elizabeth Gamble. I am a physical therapist here at Limitless PT in Cortland, New York. I am trained in pelvic health for both males and females, as well as orthopedics and sports rehab. This presentation is going to focus on male urinary dysfunctions and address and kind of uncover what the role of pelvic floor PT is for these individuals. Here at Limitless, our mission is to grow a thriving community that inspires the best possible health outcomes. And in the case of pelvic health, men typically go kind of under noticed as far as the role of pelvic health to help address some of the symptoms they're experiencing. We know that about 1 in 8 adults, so that's both men and women, will experience some symptom of pelvic floor dysfunction in their lifetime. And we know the rates of pelvic floor dysfunction are significantly higher in those males experiencing various prostate-related dysfunctions. So our goal here is to provide rehab services that focus on addressing those symptoms and those immediate impairments, but then also kind of moving the needle, so to speak, on building an individual's strength and mobility and addressing their general foundations of health and wellness. We want to set our patients up well for longevity. And so addressing their pelvic health and leading into overall functional wellness is a really important and critical role that we have and something we take very seriously here. So what we're going to discuss is kind of the what and why of urinary dysfunctions in males and how pelvic floor PT can be helpful and what a evaluation and pelvic floor PT looks like at Limitless. We're going to do our best to give you a nice vision of all of these components. This is by no means a robust, complete presentation, but hopefully enough to provide some helpful working knowledge to our providers, but also to any patients who might be experiencing some symptoms they don't fully understand, that are hard to talk about, hard to experience, hopefully uncover and take away some of those question marks. So about 6 to 8% of men may develop persistent leakage that requires the use of pads, incontinence pads, at 6 months post-prostate surgery. And 10% may continue to use pads beyond 3 years. So these are stats that are specific for prostate, prostatectomy, prostate intervention individuals. But definitely urinary dysfunction in males is by no means purely in the realm of pre and post prostate surgery or treatment. We treat lots of males or many males with symptoms that go unrelated to prostate surgery or prostate cancer. But our best working evidence and research happens to be in the realm of prostate cancer. So let's talk a little bit about micturition, which is how the bladder stores and voids urine. And we're going to talk about the uniqueness within the male pelvis and how that is different from the female pelvis. So this image is a really simple, basic image that shows a bladder as it is filling. It is not a complete image for our males, as it does not include the prostate gland, but our next page will kind of sum that up. But in general, I want to get a good idea across of what the bladder is doing and what is doing the work to help us hold urine when we want to hold urine and pee when we want to pee. So essentially, as the bladder fills, we have muscles, pelvic floor muscles, that are depicted on the lower aspect here of the urethra. And then we have urethral sphincters that are within the urethra and kind of at the base of the bladder that are all kind of constricting or in a closed position, providing what's called urethral closing pressure, meaning these things are contracted or they are activated to help close the urethra and prevent the loss of urine. And they'll do this as the bladder is filling and filling and filling as you eat and drink and as your day goes. When an individual's bladder gets to about halfway full, or 250 milliliters of fluid, they will experience what's called their first urge, which is the communication of the bladder to the brain, telling them they have to void. Subconsciously, typically, the bladder and brain decide, well, I'm not all the way full, so the urge is suppressed, and you don't really experience an urge or a need to go to the bathroom, and you continue on about your day. Until a time comes when your bladder reaches more of its fuller capacity, closer to 450 to 500 milliliters of fluid, is when that communication happens again to your brain, and your brain says, you are all the way full, you need to go to the bathroom. At which time you go to the bathroom and you can start your stream of pee when you want to start it, and it feels complete and well maintained. When that stream starts and when we sit down or stand at the toilet, your muscles have to relax, and the sphincters, the doors, have to open, and the bladder muscle contracts. And this allows the flow of urine to leave the bladder, exit down through the urethra, and out through the penis. So in addition to the sphincters and the pelvic floor muscles, males have the prostate gland. So in this image, it shows it really nicely. We have the bladder that sits here in the middle of the image. And then just below that, you can see the urethra descending out and down through the penis. We have the pelvic floor muscles, which align from the pubic bone and kind of slowly descend back, surrounding your pelvic organs until they get all the way back to the coccyx. And then we have the prostate gland, which sits at the base of the bladder and surrounds the kind of upper portion of the urethra. And so in males, the prostate gland is really critical for your continence, or the ability to hold urine and pass urine when we want to, as it creates a passive closing pressure in and of itself. You can kind of think of it like a stopper in the tub. It is creating a significant counter pressure against the urethra and the bladder to help control your urinary flow. So you can appreciate, in the realm of prostate cancer and various prostate surgeries, how removal or impact on the prostate will change what a male's urinary function and control is. So some general norms for nutrition is that the average adult, if they're drinking a recommended 60 ounces of water a day, should void about 6 to 8, sometimes 6 to 10 times per day. And that's very normal. Maybe they wake up 0 to 1 times a night, If they're older than 65, then we expect them to maybe wake up 0 to 2 times a night. In general, our max capacity, we should be able to hold urine upwards of 3 to 4 hours. And we should be able to initiate our stream of urine, maintain a steady stream, and feel complete once the stream is finished. When it comes to specific urinary dysfunctions for males, a lot of these are similar for females as well. So we have some patients who will present with high frequency, meaning they feel like they have to urinate often and frequently throughout the day. And then we have some patients who have urinary hesitancy or retention who have difficulty voiding close to that average amount of 6 times per day. And then we can also have symptoms of urinary incontinence. For those individuals with urinary frequency who feel like they are voiding every hour, every 30 minutes, they have an urge to go or they are looking for a bathroom. This is someone who may have developed some different behavioral patterns, such as second void syndrome, meaning they urinated 5, 10, 20 minutes ago and now have another urge to do so again, even though we know the bladder isn't reaching its full capacity in that time frame. Or they have triggered voiding, meaning they have come into contact with water or hearing water, or they step in the threshold of their door, or they just parked the car in the driveway, and there's this intense, almost irrational sense of urgency, and there is a mad dash to the bathroom. With urinary hesitancy or retention, this is the person on the other end of the spectrum, right, who has maybe difficulty initiating the stream, who sometimes almost feels like they have to force their urine out, and maybe their stream starts and stops. And sometimes this can occur along with some pelvic pain. And then we have some incontinence dysfunctions. So stress incontinence, this is the involuntary leakage that occurs with a sudden increase in intra-abdominal pressure, so physical stress within the abdominal cavity. Most often, this is thought of with coughing, sneezing, laughing, yelling. And then we have urge urinary incontinence. This is that uncontrollable need to urinate frequently, and that is followed along with accidental urinary leakage on the way to the bathroom, or as someone is trying to pull their pants down or sit down on the toilet. Functional urinary incontinence, this is really when a person is aware that they need to urinate, but maybe due to physical or mental limitations cannot reach the bathroom in time. And then we have athletic incontinence, which is incontinence that is really only experienced with athletics in sport. So not really with your standard day-to-day activities and physical movements, but when people are performing at higher strain rates and there's higher loads placed on their body and on the pelvis, they have symptoms of urinary leakage. So really all of those conditions are great responders to pelvic floor physical therapy, and I think would indicate for an individual that they could consult and see a pelvic floor physical therapist. What we would do in a PT evaluation is a pretty high standard of practice, but will vary based off what a patient presents with. In general, we're going to do a really great history taking to get a really broad and deep understanding of a patient's either singular component of symptom or multi-components of symptoms. And then that will guide us into our physical exam. The physical exam is often going to include some orthopedic assessment of the core, of the spine, of the hips, because these regions just interact and overlap with the pelvis and the pelvic floor muscles so much. So we're going to get a really good look at that. And then we're also going to get a good look at the loading exam. For example, if my patient expresses that, oh, I just have symptoms when I jump or when I run, then I want to have them jump and run during the assessment to get an idea of what their threshold is like, what their movement looks like, and kind of what their baseline levels are. Following that, we'll go into kind of our initial pelvic floor assessment, where we'll use rehabilitative ultrasound to look at the pelvic floor as it relates to the bladder. And we'll look at their timing, their coordination of movement, the impact of diaphragmatic breathing on their pelvic floor, the impact of their core activity on the pelvic floor, and a general sense of their endurance and just overall volitional capacity. That typically then leads us to feel that the next step might be an internal pelvic exam or a more specific external pelvic exam that is largely palpatory, but still gives us good, robust information to develop their plan of care. Apart from the hands-on examination, right, we're going to also get a look at what some of their different lifestyle features and habits are. We're going to ask and have long conversations about what they're drinking, how much they're drinking, what they're eating, and do some utilize bladder diaries and food diaries to get a really specific picture of that. So patients are often sent home with a little bit of homework that they then return with to the clinic at their next appointment. For some of these symptoms, so what does pelvic floor PT look like, right? So once that examination is complete and we've identified, for example, with high urinary frequency, that there might be some behavioral components to address. We're going to give some very distinct, specific cues and education tactics for this individual to incorporate on the day-to-day basis to reduce second voiding syndrome, to reduce the impact of some of those triggers, and to improve their sense of urgency control. If this individual shows that, they aren't drinking well or eating well, then we're going to address that with some immediate guidance on modifications. And we're going to initiate some bladder retraining, right? So we want the bladder to be able to expand to its full extent and for a person to be able to tolerate their bladder being full at its full capacity. So that comes in the form of increasing their water intake to hit our marks there, and also incorporating urge suppression strategies. In addition to those, based off the exam, if direct pelvic floor treatment is indicated, then we will proceed with specific pelvic floor training. Okay. And then again, if there's inefficiencies or energy leakages, we like to call them, along the core or the back or the hips, or with different movement patterns, right? If we can make their general movement and physical capacity more robust, then we likely will see reduced sense of loading on the pelvis, the pelvic floor, and the bladder, and improved sense of urinary control. In regards to urinary retention, we're going to do some similar things as far as addressing the behavioral patterns, giving them strategies to work around their work schedule. We're going to give them some specific goals and guidelines based off their bladder diary. So how much to drink, what to drink, maybe a little what to drink less of. And we're going to also take steps towards addressing any mental or emotional stress, anxiousness, or kind of poor mood states that they might be in. We see this a lot in pelvic floor therapy is individuals who might be in a lower mood state are seeing an occurrence of symptoms develop in the pelvic floor. So these things are not occurring separate from each other, but are oftentimes correlating with one another. So we're going to discuss that and take some actionable steps to address it. Again, we will address the pelvic floor as indicated by based on the evaluation, and improve efficiencies with diaphragmatic breathing, with spine mobility and hip mobility, and then their general muscular balance across their torso and their hips in accordance with balancing the pelvic floor function. When it comes to incontinence, so with stress incontinence specifically, so for our individuals who have leakage with the physical movement, with the intra-abdominal pressure, we are going to look at the pelvic floor muscle coordination. Is it timing up well based on the task and demand that's being placed on it? And if not, we want to retrain that. The second thing we want to look at is the strength capacity. Do the muscles have the strength capacity to meet the demand that's being placed on them? If that's not lining up, then we want to address that. If this is more of a fast twitch muscle activation issue, then we want to try to retrain and improve the capacity of those fast twitch muscle fibers to reduce incontinence that occurs with those stressful events. And then kind of similar to our other conditions, we want to maximize efficiency in the core and in the hips and just an individual's general body readiness, fitness capacity. When it comes to urinary urgency or high frequency, this is where we want to lean in on the bladder diary and those triggers and behavioral components, but also move the needle on their physical capacity, whether it is pelvic floor based or just general hip and spine, general strengthening and conditioning. And oftentimes when we get people moving more efficiently and get their hip strength improved and their core strength improved, we see a lot of symptoms of urgency and stress incontinence decrease. So all in all, that's a really small glimpse, but hopefully a little introductory information or a little glimpse into pelvic floor PT for some of these bladder conditions. For those post-prostatectomy or post-prostate interventional treatment, symptoms can be a little variable, but overall respond really well to rehab and progressive muscle training. Again, remember the prostate, whether it's a partial or complete prostatectomy or interventional medicine and treatment, the prostate is impaired. So now the muscles and the sphincters, especially the pelvic floor muscles, have to make up for that lost function or that impaired function. And so it just takes rehab and training and adapting to get them to that state so they can do that for you. But overall, We see it, I can speak to it anecdotally of the patients who come in and I've worked with. And the research is also pretty adamant and robust in saying that individuals or males who maybe start pelvic PT prior to prostate surgery and participate in PT post prostate surgery are seeing really, really excellent outcomes. So hopefully this is a nice kind of jumping off point. But as always, if there are questions, if there are follow-up concerns, or whether from a provider or through the lens of a patient, please don't hesitate to reach out. We have some offices in Rochester and then here in Central New York in the Cortland Village. We are always open to screening or fielding any questions that you might have. So please don't hesitate to reach out. And I hope you enjoyed this time and presentation. Thank you.